Welcome everyone. Thanks for joining us on this evening, 8 o'clock in the east, 5 on Pacific on the west. So we're going to get cozy tonight as we discuss on this WebEx managing advanced urothelial carcinoma in 2020 based on the Canadian consensus updates. This is an accredited learning activity, Section 1, as part of the MOC for the Royal College of Physicians and Surgeons of Canada and approved by the Canadian Urology Association. You may claim 1 hour of credit. The scientific content of this program was developed by the Canadian Urology Association. These are my disclosures. And throughout the encounter, we encourage you to type in any questions you have and send it along to us. If we have time at the end, we'll certainly get to your questions. All faculty have adhered to the following codes, as you see listed there. And for disclosures of commercial support, this program has received generous financial support from Merck in the form of an educational grant. So the aim tonight is really that we should all have, by the end of this program, a good understanding of the following few objectives. One is to really frame and understand the evidence for systemic therapies in the first line and subsequent and beyond settings for advanced urothelial carcinoma. We'll also review the multidisciplinary approach to locally advanced bladder cancer. And then at the end, we'll highlight the evolving data and future directions for advanced disease. Before we dive in, let's just get a brief introduction. Metastatic urothelial carcinoma, or UC, arises from the transitional epithelial lining of the urinary tract. And as you can see, this involves the lining of the bladder, the ureter, the renal pelvis, and the urethra. Common histologies here. Typically and historically, there's been a male predominance with a median age of 72, so these patients are typically in their 8th decade. There's a variety of risk factors, some of which are more common than others, cigarette smoking being one, for example, and various environmental exposures when they cause contact with the surface epithelium can lead to multifocal occurrence. So if we focus on bladder cancer specifically, epidemiology from the SEER data shows some common trends with other solid tumors. The predominant bladder cancer is usually captured in a localized setting. Here it's about 5% in SEER database with a variety of unknown patients, but this is probably in the real world more about 15% of patients that present with distant metastatic disease, and up to 40% of those who are initially muscle invasive can later relapse. There's a classic way of thinking about solid tumors of TNM staging, but practically in bladder cancer, it's thought of in three distinct ways. One is superficial disease. So on this diagram, that really relates to the T1, TA, the T1, or the carcinoma in situ. That's about 3/4 to 80% of the typical patient. Muscle invasive disease is T2 or greater, as you can see here, without being obviously metastatic. And of course, there's distant metastatic disease, which we'll talk about today. Throughout this encounter, we'll cover the M1 population first, but we'll also look at the Canadian statements on T4B, N1 to N3. We'll define that throughout. This is really, I think, the linchpin of the conversation tonight is this Canadian consensus statement for advanced urothelial carcinoma. I really encourage you to read this. Really authors all across the country, downloadable at the CUAJ, and I think this is really a nice, clean, informative read, but obviously data has evolved and things change very quickly. So, from an advanced urothelial carcinoma setting, first-line chemotherapy data, and it's really well captured on this slide. You can see on the left of the slide, cisplatin eligible. We've seen in publications back in 2005 data for gemcitabine and cisplatin versus MVAC. And two things to take away. One is that these curves on this slide really overlap. The median survival is not really different. And again, this is using cisplatin based. And we'll talk about which kind of a patient is cisplatin eligible in a second. Similarly on the right, these are cisplatin ineligible patients who got gemcitabine and carboplatin, or MCAVI, again, both regimens having carboplatin instead of cisplatin. Similar kind of story. You can see these curves really overlap. Medians are not significantly different. But what you will notice from these two trials, and again, it's not meant for cross-trial comparison, but just to take away the spirit, that it's very important for our patients to be able to receive cisplatin if it's safe, because you can see that in general the prognosis is more favorable for patients in the first line setting who can receive gemcitabine and cisplatin as opposed to gemcitabine and carboplatin. So there's certainly a difference. So how do we define cisplatin fit or unfit? Well, historically this has really come from consensus from surveys that were sent to a variety of international experts in bladder cancer. And in general, what was agreed upon is that patients who would be defined as cisplatin unfit either have an ECOG performance status of 2 or greater, a creatinine clearance or GFR less than 60, more on that in a second, significant hearing loss, which has defined definitions, grade 2 or greater peripheral neuropathy, or New York Heart Association class 3 or 4 heart failure. Now I'll come back to the creatinine clearance right now, because in the select patient who's otherwise well and whose kidney function is not obviously correctable through, let's say, a percutaneous nephrostomy, many of us do use cisplatin in the GFR range of 45 to 60, but simply administer it in a split dose. So as opposed to treatment for cisplatin occurring completely on day 1, it can be split over day 1 and day 8. So in general, if you're medically fit and able to handle cisplatin, we have the theoretical options of MVAC or gemcitabine and cisplatin, but for a variety of reasons, as I've mentioned, the typical age, the resultant comorbidities, the less toxic gemcitabine and cisplatin is preferred. Now in this era, there was really a sobering 5-year survival. We tried to do better by looking at adding paclitaxel to gemcitabine and cisplatin. You can see here this data published in JCO in 2012, really no significant difference for the overall cohort that included patients with lower and upper tract disease. Dose dense MVAC was evaluated versus MVAC. And again, a few things to take away. The median wasn't significantly different, but you can see that after these curves are in firm embrace, there is a separation later on, let's say about the 2-year mark, where there is appearing to be a subset of patients that may benefit from high-dose MVAC. But again, in a palliative first-line setting, generally gemcitabine and cisplatin is preferred. So just a few years ago, what was available after patients received gemcitabine and cisplatin in the first line? Vinflunine was studied, approved in Europe, not in North America. Taxanes were also available, again, paclitaxel, docetaxel, again, post-cisplatin treatment. We can see the response rates were limited, and again, overall survival was ultimately guarded. So really, until the dark ages of 2016, these were the options available for advanced urothelial carcinoma. Gem-cis or gem-carbo, depending on if you were cisplatin eligible. If patients were found to be platinum resistant, then typically they would be offered a next line cytotoxic treatment, either vinflunine in Europe or taxane in North America. Now, one thing I've put an asterisk to here is to say that if a patient had, for example, benefited from first-line cisplatin, typically clinically characterized as initial response of at least 6 to 12 months on the first-line treatment, then it's possible that you could recycle using cisplatin in those patients as well. And that's still an option that could be considered even today. So this was 2016. What's happened since then? Well, as many of you know, drugs always really develop from an understanding of basic science or molecular biology, and we see here that on this mutanome graph, the somatic mutation frequency here on the y-axis, you can see on the X bladder lies to the far right, more in line with lung cancer and melanoma. And this really paved the way for using checkpoint inhibition or immunotherapy in bladder cancer. So I think this timeline really reflects nicely that from the late 90s to really just after the mid-2010 era, most of these options were chemotherapy based. But there was an explosion really after 16 and more commonly in 2018, looking at a variety of immunotherapy options for patients who are post-platinum or have progressed on first-line platinum-based chemotherapy. So let's look at one study, Keynote 045. This study involved patients with urothelial carcinoma. Again, they could have had bladder or other tract disease, previously received chemotherapy, had a performance status up to 2, and they were randomized to pembrolizumab, which is a PD-1 inhibitor, again a fixed dose given every 3 weeks, or randomized to a control arm of really dealer's choice chemotherapy. In this trial, again, median age was about 66, a bit younger than you'd expect in the real world setting. Most of these patients had good performance status. Over a third had liver metastasis, which we know is a poor prognostic factor. There's a variety of other Bajoran and other risk factors listed here that you can review. The ultimate punchline, though, is that for the primary endpoint of overall survival, patients who received pembrolizumab had a better outcome, a median survival of 10 months versus 7 months in the control arm. This was a hazard ratio of 0.7. This was a significant trial. Now, a few things to point out. One, that in the control arm, it's always really important to see what patients receive next when you consider survival. And we can see that for those patients who received the chemotherapy arm and were alive at the 2-year mark, nearly 2/3 received a PD-1 or PD-L1 therapy. So, I think very reasonable post-control arm treatment. You can see here by these plots, ultimately the point to take away is that all of the point estimates seem to favor pembrolizumab in terms of hazard ratios, all to the left of unity. There's perhaps some signal that maybe those patients who had a slightly higher CPS score perhaps had an interval that had provided more benefit, but really ultimately all of this is to the left. And the take-home point I would say here is that it really didn't matter what your PD-L1 or in this trial a combined positive score level was, patients benefited from immunotherapy in this setting. And do we have any signal of which patients would benefit better? Well, certainly, given that the response rate was only 21%, that means the majority of patients who are treated will not have an objective response. Again, this is tempered by a complete response rate of about 12%. And you can see that how will we know response? I mean, typically and very commonly for single-agent pembrolizumab, the median time to response is about 2 months, so by first CT scan typically. But as you get more granularity, and perhaps unsurprisingly, you can see that those patients on the left here who had a complete or partial response, the magnitude of benefit from immunotherapy versus chemotherapy was very significant. This hazard ratio is 0.14 now. The median for the pembrolizumab was not reached at that data cutoff. And so it really shows you that if your patient responds, they're more likely to be the one driving the survival benefit that we saw in the clinical trial. Even patients, though with stable disease, there is still a separation of the curves. So that was nice to see. Again, this hazard ratio is creeping up, though, still a significant benefit. And of course, if your patient has primary progressive disease, or for whatever reason the response wasn't evaluable, there didn't appear to be a significant benefit from receiving immunotherapy in this setting, as you'd expect. This tornado plot tries to give us a sense of, while there's efficacy, what is the cost in terms of toxicity? And you can see in dark here are grade 1 or 2 toxicities, and the lighter shadowing is grade 3 to 5. And you can see that there was certainly more toxicities prevalent in the chemotherapy group, and certainly more grade 3 to 5. 7.5% of patients in this pretreated setting experienced febrile neutropenia in the chemotherapy arm. So certainly a very tolerable treatment. And I think this really relates to what we see in the unselected or real-world setting. So efficacy, toxicity, importantly in trials, it's key to look at quality of life. And so hopefully you can appreciate blue here is the pembrolizumab, yellow here is the chemotherapy, and being higher on these validated quality of life scores is better. So here you can see that regardless of the validated score, it appeared that the immunotherapy arm performed better in terms of quality of life. That's really critical to be able to tell our patients lifespan is better with the treatment, we'll have less toxicities, and potentially have an improved quality of life. So that's a very important trial, but it's not the only one. Not to be outdone, atezolizumab was also evaluated in a phase 3 setting, the IMvigor211. This was on the basis of the phase 2 study that preceded it. Again, very similar population. These patients had metastatic urothelial carcinoma, previously treated with chemotherapy, ECOG performance status up to 1, and again randomized dealer's choice chemo versus atezolizumab. Now, importantly in this setting, and for those of you interested in clinical trial design, it's really important to look at the stats. So the primary endpoint was overall survival, but it was tested in this gatekeeping or hierarchical design, meaning that in order to look at a specific subset of population to define a positive endpoint, the previous population needed to be positive first. So this trial was designed to look at the IC2-3 population, and again, this is really a measure of PD-L1 status. We saw CPS or combined positive score in the keynote studies, ICs in the IMvigor platform of trials. Ultimately, this is defined as having 5% or more of tumor-infiltrating immune cells. So this was the first gatekeeping population that they evaluated. And you can see here, these curves are really not that different. Median survival, pretty close, between 10 and 11 months. Hazard ratio of 0.87, a confidence interval that crossed 1. This was not a significant finding in this group. And due to the hierarchical design, no further formal statistical analysis was permitted in the IC 1, 2, 3 population or the intention to treat. So this was unfortunately a negative study. We could still look at these populations at least to understand if there was some signal we could derive from this. So this was the all-comer population, median survival benefit difference of about 1/2 month, hazard ratio of 0.85 and a p-value of 0.038. But again, begs the question of whether this is really a clinically meaningful benefit. And again, because of the gatekeeping design, was not statistically significant. And the ITT population, there was some other signal that we could learn interestingly. If the control arm or the patient is on the control arm were treated with a taxane, it appeared that the experimental arm or atezolizumab here performed better with a hazard ratio of 0.73. Again, no formal statistical p-value, but the confidence interval did not cross 1. Whereas with vinflunine, so again, patients in the control arm who were treated with vinflunine, in that group, the immunotherapy patients didn't seem to really have a significant magnitude of benefit, hazard ratio of 0.97. So it's very interesting to note that perhaps it depended on what the control arm was, but biologically we would want to see a benefit for an experimental arm regardless of the dealer's choice control arm. Those were 2 phase 3 studies we reviewed, but there's a variety of other trials that were evaluated, and in fairness, we should mention all of them. Nivolumab was evaluated, this is a PD-1 inhibitor in a phase 2 single-arm trial. Avelumab, a PD-L1 inhibitor, was also evaluated in an early phase study, and durvalumab as well. Now, what we can take away is that the response rates here on this row are all between 15 and 20, let's say 25%. It tells you that the responses are somewhat similar, that the majority of patients will not experience a response that we treat in clinic. 4 out of 5 may not. But the only drug evaluated in a phase 3 setting to show a significant overall survival benefit is pembrolizumab, and therefore, in most jurisdictions, certainly in Canada, is what is used as a de facto agent. So we've talked about immunotherapy post-chemotherapy. What about using immunotherapy first, in the first line advanced urothelial carcinoma setting? We certainly have data in that context. The Keynote 052 study looked at first-line pembrolizumab, again, in cisplatin-ineligible patients. Now, we've already reviewed those criteria, so you know them well. Single-arm study randomized to all patients actually getting pembrolizumab, but here, protocol written to receive treatment up to 24 months. The primary endpoints here were overall objective response rate in all patients and patients with PD-L1 positive tumors. Now, this median follow-up was about 11.5 months. So in this type of patient population, you can see that the median age was 75, and that's typically what we would see in a bladder cancer patient setting. Really nice to see that even 11% of patients were over the age of 85, pointing out a bit about the disease characteristics here in general, but also that it's important not to use chronology or chronologic age alone as an inclusion criteria for our patients. 40% of these patients were ECOG performance status 2, and 85% had visceral disease. So in terms of the primary endpoint of objective response rate, you can see that the objective response rate here was about 29%, of whom 8% had complete response. Now that should be framed in the context that in a post-platinum or post-chemotherapy setting, that response rate was around 21%. So do we know, given that objective response rate, which is signified by this dashed line, which patients maybe did better than that? And here you can see, we start to see where this CPS or PD-L1 status might matter. So if your PD-L1 status was quantified as 10 or more, your response rate was over 40%, whereas if it was under 10, then it was below that overall objective response rate we saw in the trial. Lymph node only patients appear to fare better, and this is really, I think, a signal more of disease biology in general of bladder cancer rather than this particular drug or trial. Survival from a median survival perspective, this was 11.5 months. And again, this is a first-line setting. Granted, these patients are cisplatin ineligible, but certainly we would have expected to see a slightly higher result, ideally, in a first-line setting. When you look at this outcome, overall survival by PD-L1 subgroup, you can see that PD-L1 positive patients had a survival of 18.5 months compared to those who were deemed negative or CPS less than 10 of 10 months. So there is a signal in a first-line immunotherapy setting of potential benefit pending your PD-L1 status. This slide is really just to point out that single-agent pembrolizumab in this context was very well tolerated, really no new safety signals. The amount of grade 3 or 4 toxicity was pretty low. Again, not to be outdone, atezolizumab was also evaluated in this setting. First-line cisplatin eligible as part of cohort 1 for the IMvigor210 study. Again, here patients received atezolizumab every 3 weeks until RECIST confirmed progression, similar endpoint of objective response rate. So just to summarize these two, and again, it's not meant to be a one slide for a cross-trial comparison, but really just to frame things in context. So we can see that with the atezolizumab and pembrolizumab studies, again, under 2 years of follow-up for both, slightly longer follow-up with the atezolizumab group. Reasons for being cisplatin eligible listed here, but you can see that the response rates of 29 or 24% for the all-comer population. Interestingly, PD-L1 positive seem to have a very significant improvement in the response rate compared to the ITT population. Some benefit here in IC2-3, but that magnitude isn't as significant. I think rather interestingly, the overall survival for pembrolizumab was 11.5 months, raised to 18.5 if you were by that trial defined as PD-L1 positive. But your median survival in the IMvigor210 study went from 16.3, and if you are deemed PD-L1 positive, somehow that went down to 12. So that may be a combination of treatment or trial design, or perhaps more likely the assay that is used to define PD-L1 status. Again, we're speculating on that, but this is just to put things in context. So with these trials, the status of pembrolizumab and atezolizumab was such that they were granted accelerated US FDA approval in 2017, which means it was really pending further confirmatory studies. Now in June 2018, based on data available at that time, and we'll get back to this later, the US FDA and the European, or the EMA, sanctioned IO agents, so these single-agent immunotherapies, as first-line therapy only for those who are PD-L1 high, cisplatin eligible, or for patients who couldn't receive any platinum-containing chemotherapy. Now in Canada, this is not routinely available or funded inside Canada in the first-line settings, and most patients would avail of this type of treatment as part of a clinical trial if available at your local center. So I think in the first while in this talk, we've really covered comprehensively, in a quick review, the status of really first and subsequent line treatment in urothelial carcinoma as it stands today. We're going to look forward to what is coming down the pipeline, but let's pivot a bit and look at the management of locally advanced bladder cancer. Because this is something I think the consensus paper really did a good job of pointing out some guideposts and some future areas for research that we can try and work together on. So again, just some definitions. CT4B, so these are typically bladder urothelial carcinomas that invade the pelvic or abdominal wall or adjacent bowel rectum and is deemed initially unresectable. There's definitions for N1 or N2 versus N3, but ultimately the issue that I think the paper points out well is that the evidence outlining what we should do in a very robust, randomized way is really lacking. It's not well defined about what to do. And I think as you read that paper, they put up a nice table 5. And again, it's not to go through this in detail, but this was some of the available data at the time, looking at what to do in patients with these types of disease. You'll notice a few things. One, patients vary from 300 in one sample all the way down to maybe 30. When we look at this being a lymph node positive patients, there's variabilities all throughout as to whether clinically staged lymph node positivity actually had histologic confirmation. So there's significant variability in all these trials. There's furthermore limited numbers of patients in a locally advanced setting in this collection of data that actually had patients who received radiation. Most patients here received radical cystectomy or a pelvic lymph node with a pelvic lymph node dissection. Now we know that radiation is used quite a lot in our centers, so that's another gap that we can hopefully try and fill with our national research. There's also limited numbers here with upper tract urothelial carcinoma, again, mostly confined to bladder. And when patients receive radiation or surgery, the criteria for selection between them was also not clearly or granularly defined in all these studies. So the real takeaway point is I think we do need a consensus. We certainly need some guideposts. But the data on which we're basing that really shows that there's areas of unmet need here. So ultimately, what is the consensus we take away? I think a real takeaway point in this segment of the talk is that these patients who have locally advanced disease, so again T4B, N1 to 3 bladder urothelial carcinoma, really should be seen or assessed or discussed in a multidisciplinary forum, having experienced input from uro-oncology, medical oncology, and radiation oncology. Now, there's many centers across the country that do this. I can speak for the Juravinski Cancer Center. We have a multidisciplinary bladder clinic. So this is where patients with this type of presentation, locally advanced cancers of this context, would be seen in a dedicated clinic. This dedicated clinic would allow patients to have a urologic, a medical oncology, and a radiation oncology opinion in the same room at that same visit, kind of a one-stop shop for patients where all three specialists come together, have reviewed the charts and the files in advance, and provide a consensus opinion with the patient in the room. And I think patients really enjoy having that face-to-face contact. If that's not possible in all centers, certainly review at tumor board or case conferences where all the opinions are sought, I think is important. I think really the takeaway is that these patients really need to have multiple inputs to provide cohesive care plans. The next takeaway, and really building off of that, is that it's important they be seen in a multidisciplinary context because locally advanced bladder cancer can still have a cure rate. And so it's really important that we leverage multimodality therapy if it's indicated. In general, in suitable patients, a preferred approach may be to commence with systemic therapy up front, meaning 4 or up to 6 cycles of platinum-based chemotherapy as a first-line treatment, ultimately giving a sense of are patients going to be primary refractory to this disease. And you'd want to know that before you proceed with multi-week localized radiation treatment or a radical cystectomy. But after the treatment with first-line systemic therapy, it's very important to, depending on that, with re-imaging and perhaps a direct view of the bladder, to then get a sense of whether a radical cystectomy or radiation can be offered. And the only way to really do that is, again, having multidisciplinary discussion, a case conference review, which we do routinely for our patients. So that's the localized setting. So let's pivot now to more future looking. What's next on the horizon? So if we use the context of advanced urothelial carcinoma and looking down the road, and again, this was taken from the consensus statement that I hope you all review, there's a variety of exciting phase 3 studies. Now, the Javelin Bladder 100 looked at giving a treatment after patients received 4 or 6 cycles of chemotherapy. Could patients be maintained on a therapy or just provided best supportive care and observation? We'll get to that in a second. These other trials are all evaluating, in some way, combination immunotherapy with chemotherapy versus chemotherapy alone, and in some situations versus immunotherapy alone. So that's the IMvigor 130, 361 are doing that, and the Danube study. We can see that Checkmate 901 is also looking at combination immunotherapy versus chemotherapy and then combination immunochemotherapy as well. So these are all provocative studies and all will hopefully build a story for us to really tease out if there's a benefit of putting multiple treatments up front. Now, a few things before we dive into that. The IMvigor 130 and 361. The Data Safety Monitoring Committee for both of these trials in May 2018 found that patients who received just immunotherapy alone, so the monotherapy IO arms, and had a low PD-L1 status, these patients had worse survival compared to patients who received cisplatin or carboplatin-based treatment in that setting. And therefore, the trials were actually amended such that the monotherapy arms remained open only to patients whose tumors had high PD-L1 status. That's important to keep in mind as we look to these trials because it begs the question of whether those treated with carboplatin were in fact driving the findings that caused this DSMC recommendation. So IMvigor 130, this was reported at ESMO in 2019 in Spain. Again, this was a first-line trial looking at locally advanced metastatic urothelial carcinoma, no prior systemic therapy, allowed to have performance status up to 2, and randomized 1 to 1 to 1. Arm A was atezolizumab plus the doublet chemotherapy of a platinum plus gemcitabine. Arm B was immunotherapy alone, that's atezol monotherapy. And again, Arm C was placebo and combination chemotherapy. They were stratified by PD-L1 status, the investigator choice of whether they received cisplatin or carboplatin, and the Bajoran risk factor scores. Now, you've heard me say this already, but it's very critical to look at the statistical design. So you can see the co-primary endpoints here were investigator-assessed PFS, progression-free survival, and overall survival of Arm A versus C. So that's this arm, so 2 chemos and immunotherapy versus the 2 chemos and placebo. It was again a gatekeeping design or a hierarchical approach such that if these findings were positive, then we could make inferences for Arm B versus C. So really Arm A versus C had to be clearly a winner before we could move on. So let's keep that in mind. Baseline characteristics, again, these were, I guess, a typical phase 3 trial population. These patients all had a median age of around 70. You can see that PD-L1 status defined as immune cell staining, pretty well balanced between the two groups. What's interesting is that only about 30%, or let's say about a third of patients, received cisplatin chemotherapy. And again, we talked very early at the start about the importance of being able to receive cisplatin, given what we think is the prognostic outcome of those patients. But here that only made about a third of the patient population, so that's really important. Now the reasons for this were mostly renal impairment, and presumably this was not fixable through a procedure-based method. So over 2/3 received carboplatin. That's important to keep in mind. So here was the progression-free survival, Arm A versus C, for the intention-to-treat population. The blue curve here is signifying the experimental arm of atezo plus chemotherapy. You can see that the median PFS was slightly different, perhaps 1.9 month benefit, translating into a stratified hazard ratio of 0.82 and a one-sided p-value of 0.207. So this was a significant finding from progression-free survival. The question is this clinically meaningful to have a 1.9 month benefit in progression-free? We can see that point estimates look like they're to the left of the unity, but a lot of these wide confidence intervals, it makes you ask the question of, certainly having further follow-up. But remember, we talked about how most of these patients received carboplatin, but actually the magnitude of benefit may have been better if you received cisplatin, as you might expect. In that situation, the median PFS was up to 8.8 as opposed to 7.1. So again, just pointing out that those patients who received cisplatin, perhaps if that had been a larger part of this trial, certainly did better. The endpoint of overall survival, so again, Arm A versus C, more than 50% of events, a hazard ratio of 0.83. You can see these curves, a lot of censoring here still. There appears to be some separation, certainly a median survival of 16 months from 13.4 for the control arm. Now this p-value is important to interpret carefully. It says 0.027, and that certainly is legitimate, but the alpha spend or the statistical design was such that at this interim analysis, the boundary to be significant was 0.007, and so that was clearly not met here. So we still don't have a statistically significant benefit technically for Arm A versus C, and we'll certainly want to keep in mind on these median numbers as further follow-up occurs. Similar kind of story though. You can see that those patients who received cisplatin, that benefit in terms of median survival for the experimental arm was up to 21.7 versus 14.2 if you received carboplatin. Control arms kind of performed similarly. And that really points out again that if patients can get cisplatin, the magnitude of benefit in terms of the difference of hazard ratios, not for direct statistical comparison, but just to give you a sense, that certainly looked certainly better. And again, patients were stratified by what type of chemo they received. So I mentioned that without statistical significance of the Arm A versus C comparison, we couldn't get into a lot of our Arm B versus C, but just to show you that perhaps one hypothesis for why these curves kind of cross here is that the trial was amended. Remember that those who had low PDL1 status uh, could not get the monotherapy with the amendment. And so you can see here that those who were PDL1 low, certainly these curves appear to cross at some point. Those who were PDL1 high, uh, you can see that the monotherapy arm here appears to be doing better. But again, very early on, limited number of events, and we'll get to further follow-up if the hierarchical design of statistical significance is met. In terms of response rates, really nice to see that nearly 50% of patients had a confirmed CR or PR, and of which CR made about 13%. So that was, I think, quite nice to see that. In terms of safety, you're putting a doublet chemotherapy with an immunotherapy agent. Interestingly, not a lot of difference in terms of grade 3 toxicities or in general compared to the placebo plus the combination chemo. And atezo on its own, for those of us who've used this drug, I think we'd agree it's generally a very well tolerated regimen. So that was one of the frontline studies, and I encourage you to keep an eye on this space as there will be more trials reading out in the next year or two. I mentioned the Javelin Bladder 100. This was the switch maintenance. So again, those patients received first-line chemotherapy up to 4 to 6 cycles, had not progressed, were randomized to either best supportive care and active surveillance, or receiving a maintenance treatment of PD-L1 avelumab. And again, this is the design. We don't have any granular data as of this filming, but we do have a recent press release in January showing that this trial was positive, or at least met its primary endpoint of overall survival at the planned interim analysis. So that's very exciting and certainly something we'll want to keep an eye on. So what else is there? We've talked a lot about chemotherapy and immunotherapy. This is a diagram we published in our expert opinion piece late 2018. It's really just to display graphically, or at least in a figure, a few things. One, we know well about PD-1 and PD-L1, the interface between our immune cell and the cancer cell. But there's other pathways in bladder cancer which has such a rich, diverse biology. So the FGFR pathway, or the fibroblast growth factor receptor pathway, patients with urothelial carcinoma, nearly 15 to 20% of these patients have mutations, translocations, amplifications, or some form of alteration of this pathway. And in fact, some genomic analysis is showing that those upper tract disease, that number may even be higher. So the FGFR pathway is really one of interest, and we want to interrogate this for potential therapeutic benefit. Nectin-4, so this is a family, this is a member of the nectin family of cell adhesion molecules, so very commonly expressed in urothelial cancer cells. And so having an anti-Nectin-4 monoclonal antibody would be very helpful and potentially specific for bladder cancer treatment. And so the thinking is that having this type of agent, which is a monoclonal antibody with a protease cleavable linker, could perhaps be taken up by the cancer cell, endocytosed, degraded, and this active agent is released inside, specific for the bladder cancer cell, leading to cell cycle arrest and apoptosis. And we do have a drug that looks at this. It's called enfortumab vedotin, or EV for short. And so let's start there. EV was evaluated in a phase 2 single-arm study. Again, this is a single-agent EV, or enfortumab, in patients who previously received platinum for advanced urothelial carcinoma. And you can see that in these patients, the response rate was 44%, which is really nice to see, 12% complete response rate. And this swimmer's plot shows you how durable some of these, or long-lasting some of these responses are. So really nice to see single-agent efficacy, at least, or activity in the EV201 trial. It's important to get a sense of were there any safety signals that were perhaps off target. But again, most of this was on target. This drug is tolerable. Peripheral neuropathy and rash are anticipated on-target toxicities. So enfortumab evaluated in this study. There is currently an ongoing EV301 study. We're waiting for the data readout there, but that is a phase 3 trial looking at enfortumab post-chemotherapy and allowing post-immunotherapy for patients to receive this agent, again, in a randomized phase 3 setting. So keep an eye out on that. But the field moves fast. There's already data, and we saw this most recently at GU ASCO, initially presented at ESMO in 2019, looking at the combination of enfortumab with pembrolizumab. So trying to see if perhaps putting an agent against Nectin-4 and PD-1 inhibition can lead to a synergistic effect. So EV103 really expanded a dose in patients who had or were cisplatin ineligible. So we've seen this story before. And we've seen data for atezolizumab and pembrolizumab in this setting, and you'll recall some of the response rates there. Really exciting. This waterfall plot showing the response rates, really the reduction in size of the tumor in patients who received pembro plus EV or enfortumab, a response rate of 73%. That is really impressive, again, in a pre-treated patient population. The shading of the bars really mean, and I think the takeaway is that responses here are really irrespective of your PD-L1 status. So this is, I think, really exciting, impressive early phase activity of this combination, worthy of further study. This slide really, I wouldn't take too much away from any slides that have just a single arm of a Kaplan-Meier curve, but it's the takeaway that the median PFS is 12.3, and the median overall survival was not reached at this follow-up, but a 12-month survival rate was 81%. So again, these are pre-treated patients. These patients are cisplatin ineligible, I should say, but now we have a phase 3 study looking at enfortumab alone in pre-treated patients, moving it sooner, combining with pembrolizumab in cisplatin ineligible, and voila, there'll be a phase 3 study looking at first-line enfortumab plus pembrolizumab coming your way shortly. Really importantly, I think the on-target toxicities that we'd expect with enfortumab and the typical kind of immune-related adverse event we saw with single-agent pembrolizumab did not really appear to be significantly higher when you put the two together. So very known safety signals for the two drugs separately, at least in this EV103 readout. So that's looking at pembrolizumab plus enfortumab. We reviewed enfortumab data on its own. What about FGFR targeted therapy? So erdafitinib, again, is evaluated in the BLC 2001 study. This was a phase 2 open-label multi-center study. So again, these patients were locally advanced or unresectable urothelial carcinoma, progression on prior chemotherapy, and you were allowed prior immunotherapy, or you could be chemotherapy naive, but cisplatin ineligible. And ultimately, when the right dose was found at 8 milligrams per day, allowing an up titration to 9 milligrams per day, 99 patients were evaluated in that selected dose, regimen 3. And so this patient population, median age of about 68, again, just the takeaway here, that a very representative typical population. 80% of patients had visceral metastasis, and again, median survival here was median survival follow-up time was 11 months. And again, we see very impressive data looking in a pre-treated setting, looking at erdafitinib, having FGFR mutations or alterations, a response rate of 40%. When you add to that a stable disease rate of 39%, this might suggest a disease control rate of nearly 80% with this treatment. So I think that's really impressive. These response rates were seen similarly regardless of the receipt of prior chemotherapy, yes or no, number of prior treatment lines, presence of visceral metastasis, or baseline characteristics. Now again, the takeaway really is that the median PFS here is 5.5 months, the median overall survival was 13.8 months. At the bottom here, keep an eye on this. So we saw the response rate of about, let's say, 40%, but there was a subset of patients who received immunotherapy prior to erdafitinib. Interestingly, the response rates to erdafitinib in patients who previously received immunotherapy was up to 60%. So perhaps there's a signal here that patients who would have priorly had a maybe not as robust response to immunotherapy have a very significant benefit to erdafitinib. And again, these patients all had FGFR alterations, which I think reinforces that if we're able to test for this, we should be doing this early in the treatment for advanced urothelial carcinoma. Very important to get a sense in these early phase studies of unique signals of tolerability or toxicity. And the thing to take away here is that most grade 3, certainly we saw some hand-foot syndrome that you might expect, but the one thing to take away is the ophthalmic manifestation. So central serous retinopathy or other ocular events, these patients really need to have baseline and on-treatment ophthalmic or slit lamp examinations. Things like blurry vision, conjunctivitis, increased lacrimation can all occur. So hopefully you've seen that from the 90s to mid 2010 range, we had significant chemotherapy available. But now look at the explosion of options available from 16 onwards. We've talked a lot about PD-1 or PD-L1 inhibitors. We've now confidently seen genomic alterations, a rational option available for these patients with FGFR mutations, and also the availability for enfortumab, um, which now has FDA approval. And the future aspects, I think, are going to be how do we combine these rationally to look at synergy, but also how can we move this earlier and earlier on into the disease space, because it is a clinical spectrum in urothelial carcinoma. And this slide just really reinforces, I think, the takeaway and my future optimism of the diverse biology that bladder cancer has. Now, by no means is this meant to be interpreted as a treatment algorithm for how we're in real time selecting or guiding treatment right now. But it's just to point out that whereas in breast cancer and lung cancer, we have very nice biology and tests that we can use to really dictate what treatments patients receive, maybe one day we'll get there in GU cancers and particularly bladder cancer. There's a rich amount of data in the muscle invasive setting pointing out these potential phenotypes of luminal or basal type bladder cancers. There's distinctions among them and perhaps even potential therapeutic benefits that might differ. And again, we need translational investigations, we need prospective validation, but I think it really reinforces the optimism for having biologically driven randomized trials that can really leverage the deep diversity we see in urothelial carcinoma. So with that, I'll wrap. This is a summary, and I think the take-home points that hopefully you've enjoyed tonight. And just to reinforce a couple of things. One, platinum-based chemotherapy is still a cornerstone in the first-line treatment for advanced urothelial carcinoma. You have seen data tonight on PD-1 or PD-L1 immunotherapy options, but again, that does depend on your PD-L1 status or your ineligibility to receive any platinum-containing treatment. But again, this is not currently funded in all provinces across Canada. So if that's an interest, certainly there are clinical trials trying to leverage immunotherapy in these patients. When we look at subsequent or second-line treatment, now we have a variety of options available and coming down the pipeline. Immunotherapy is present. PD-L1 testing is not needed to select for immunotherapy treatment post-platinum. However, you have now recently heard about FGFR alterations, the importance thereof, and that testing should be performed and hopefully in the near future can be performed in select centers for patients who have metastatic urothelial carcinoma. The reason I say that is that recently there has been a Health Canada a notice of conditional compliance for erdafitinib in Canada, so perhaps a testing program will soon roll out. And if that's the case, then I would encourage testers to think about this early on in your patient's treatment trajectories. And finally, ultimately, the therapeutic landscape of bladder cancer is really drastically changing. Chemotherapy was really the harbinger for 90s and 2000s, but you can see how much that has changed recently. So as we get more options in a salvage or first-line setting, we're going to look at combining these in a muscle-invasive setting, perhaps non-muscle invasive setting, really pointing out to how much our treatment options will evolve, that hopefully bladder cancer or urothelial carcinoma in general will benefit from genomic profiling so that we can bring precise, rational combinations for our patients. And ideally, all of this together and trying to rationally use multidisciplinary avenues will help maintain the remarkable recent progress we've seen in urothelial carcinoma. I'll stop there. We have time for any questions, and if not, I invite you to provide any feedback you have, and it's certainly been a pleasure sharing tonight, talking with urothelial carcinoma. We look forward to seeing you again. Thank you.